And these two blocks are, very important from that point of view. First of all, the anatomy of the adductor canal. It is also known as subsartorial canal or Hunter's canal, and it is basically why subsartorial canal, because the roof is formed by the sartorius muscle. So the extent of this canal, it is actually the aponeurotic tunnel, and the extent is from the apex of the femoral triangle to the there is a hiatus in the tendinous or the tendinous opening in the adductor magnus below. It is actually a triangular, triangular space, or it's a intramuscular space, because it is surrounded by the muscle from its all the three sides, and it occupies in the medial 1/3 of the thigh. The roof is formed by the fascia containing the subsartorial plexus and the sartorius muscle, and posteriorly it is surrounded by the adductor longus and adductor posterior-medially, and laterally the boundary is formed by the vastus medialis muscle. So you can see that this is the adductor canal. So posterior anterior laterally it is bounded by the vastus medialis muscle. The roof is formed by the sartorius, and the posterior medially it is bounded by the adductor longus and adductor magnus muscle. Coming to the contents of the subsartorial canal or adductor canal, the main contents are femoral artery, femoral vein, saphenous nerve, posterior division of the obturator nerve, and nerve to vastus medialis muscle. So this is the sono anatomy of the adductor canal. You can see this is the medial side, this is the lateral side, this is vastus medialis, this is adductor longus, the roof is formed by the sartorius muscle, and this is the femoral artery, and the saphenous nerve lies here. So this triangular space is known as adductor canal. The other nerves they are present in the adductor canals are the medial femoral cutaneous nerve, the medial retinacular nerve, and branches of anterior and posterior division of the femoral nerve. And these nerves are also blocked when you give the adductor canal block, and that is why when you give this block, you will get a more extensive sensory block than the distribution of when you compare with the distribution of the saphenous nerve, you will find more extensive sensory block. So all these four nerves are also blocked. And the study which was published by David Bond et al., that adductor canal block is more than just a saphenous nerve block, and this study was published in Regional Anesthesia Pain Medicine in 2009, and it was the first publication basically describing the adductor canal block as alternative to facial nerve block, femoral nerve block. Coming to the relations in the adductor canal, this is very important from your point of view, because when you see the upper part of the canal, you will find that femoral artery is anterior and femoral vein is posterior, and the nerve, that is the saphenous nerve, lies lateral to the artery. And when you go put a probe in the lower part of the canal, you see the femoral vein is more lateral, artery is in the middle, and this saphenous nerve lies is the most medial part. And one thing you remember that saphenous nerve is always anterior to the femoral artery, and it crosses from lateral to medial during its course to the from proximal to distal. What are the indication of these blocks? So it is again on the depending on the type of volume you use. When you use less volume for procedures like knee arthroscopy, ACL reconstruction, or you can use in combination with sciatic nerve block for surgeries or for lower leg or foot or ankle surgery. And high volume blocks are basically used when you use this block, adductor canal block, as a whole sold for a total or unicompartmental knee surgery, where you use 20 to 30 mils of local anesthetic. So you can see that this is the part which is supplied by the actually medial side of the knee joint, and the medial side of the tibia is supplied by the saphenous nerve, which is mainly blocked in this block. The contraindications are the same as contraindication you will see in other nerve blocks, and complication, there is no specific complications are related with this adductor canal block. So, goal of this is to visualize the femoral artery below the sartorius muscle and place the needle tip just medial to the femoral artery below the sartorius muscle and deposit 5 to 10 mils of local anesthetic until it is spread around the artery under the under the ultrasound visualization. Coming to the procedure, how to perform it: confirm the operative site. Confirm the operative site. Make this thumb rule that before putting any block, you should confirm the site and with the patient and where you have to put, and check the limb is marked and correspond with the information on the consent form, and then apply full non-invasive monitoring, secure an IV access, and if required proceed with sedation or induction of general anesthesia or spinal anesthesia as per your anesthesia plan. Then patient position is, for putting adductor canal block, patient should lie supine with limb should be slightly abducted and it should be flexed at knee joint, that is frog legs position. So, this is the where it is the medial side of the thigh, the limb is slightly abducted, externally rotated, and should be flexed at knee joint. Then clean the area with chlorhexidine, stand on the side of the patient to be blocked, and keep the ultrasound machine opposite on the opposite side and face the screen on your side. Place a high frequency linear probe on the anterior aspect of the femoral thigh, patient's thigh. Adjust the depth of your survey to 4 to 6 centimeter. Identify the femur, which is usually at the depth of 3 to 5 centimeter, and then move medially until you will get a sartorius muscle, which is a triangular muscle and forms the roof of the adductor canal. And see the femoral artery, whether it is which lies just under the sartorius muscle. Then remember the following things: that saphenous nerve is almost too small to be reliably imaged, and aim of the technique is to deposit the local anesthetic under the sartorius muscle and around the femoral artery, and advances the needle into the adductor canal by traversing the sartorius os vastus medialis muscle, and when you reach the lateral end of the femoral artery, then aspirate for any whether blood is coming or not, and then inject 2 mils of saline to confirm is spread around the femoral artery, and when you are sure, then only you inject the local anesthetic. An out of plane technique is approach is also acceptable, because sometimes the needles are small, not available, so you can opt out of plane technique, and there are less chances of like perforating the artery, and in out of plane technique you go through the substance of the sartorius muscle. So, there are difficulties in identifying, because femoral artery is a very important landmark in adductor canal block. So, you have to identify the femoral artery, and if it is difficulty, then you have to do that. First check the depth is adequate. Depth of your survey should be 4 to 6 centimeter, and move the probe circumferentially around the thigh towards medial side and see whether femoral artery is present or not. Then use color Doppler also for femoral artery, and if difficulty still persists, then follow the femoral artery distally from the inguinal crease and until the sartorius is seen superficial to it. Precautions you take: that at the level of adductor canal, the femoral vessels and nerves, they are in the same compartment, in contrast to the femoral vessels and nerves at the inguinal ligament, where the femoral nerve is separated by fascia iliaca. So, in adductor canal you should be very careful about because they are present in the same compartment, there is no separation by any fascia. So, then extreme caution should be taken to avoid any IV injections. Also, sometimes the vein is not, only you are concentrating on the artery and vein is not visible. Vein is not visible because there is you are putting pressure on the vein by your transducer. So, the pressure should be adequate. Okay, before injecting you just put a adequate pressure, so that vein should also be visualized. So, coming to the summary, that adductor canal block is relatively a new block with promising results, and compared with femoral nerve block, adductor canal block results less reduction in the quadriceps muscle strength, because all the motor fibers to the vastus muscles and other which are the which flex the knee, they are spared, because all arises above the adductor canal. Only the nerve to vastus medialis is present in the adductor canal, which supplies the there is a sometimes partial weakness is there, and injecting large amount of local anesthetic in the adductor canal affects not only the saphenous nerve but also nerve to vastus medialis and also the terminal ends of the posterior obturator nerve. So, this block is very important in relieving the pain in knee surgery. So, this is the summary. You have to concentrate on the initial setting, that depth should be 4 to 6 centimeter, frequency is 3 to or 5 to 13 or 6 to 13, or linear transducer, then patient position, then transducer position, then concentrate on femoral artery whether it is visible or not. If it is visible, then advance the needle in plane towards the femoral artery. Your goal is to place the needle in the medial to the artery, and if it is not identified, then start from the inguinal crease. The next block is obturator nerve block. As we know that obturator nerve is arises from the ventral rami of lumbar plexus L2, 3, 4, and it travel under the psoas major muscle and lies on the medial side of the this muscle. So, this is the obturator nerve which arises from L2, 3, 4, and here is the psoas muscle is present. So, this nerve lies on the medial side of the muscle, and in the obturator foramen, this is obturator foramen, it emerges out from the pelvis through obturator foramen along with the other vessels, and then divide into anterior and the posterior obturator nerve. One thing you should remember, there is a accessory obturator nerve is also present in 1/3 of the population, which joins the anterior branch of the obturator nerve and supplies the pectineus muscle. So, this is the area which is supplied by the obturator nerve, that is medial side of the thigh. Now, the sensory supply of the obturator nerve, it supplies the skin on the medial side of the thigh. The motor supplies the anterior division supplies the hip joint, and the posterior division supplies the knee joint. Obturator nerve is spared, this interest is created because this nerve is spared in 3 in 1 block. Okay, so with the introduction of the ultrasound in our practice, we can successfully block the obturator nerve. Indications are medical. There are some surgical indications, some medical indication. So, surgical indication are relief of painful adductor muscle contractions, then prevent adduction of thigh during transurethral bladder surgery, and additional analgesia after major knee surgery. And non-surgical indications are spastic adductor syndrome, that is present in hemiplegia or paraplegia. How to perform this block? You should ready with the equipments. So equipments you should ready are ultrasound machine with linear probe of 6 to 13 and adjust depth of 4 to 6 centimeter, then sterile gloves, gel and gloves, standard nerve block tray, and then a 20 ml syringe containing local anesthetic solution, a 10 ml syringe containing sterile saline, a 10 centimeter, a 21 to 22 gauge short bevel insulated needle, and there is a peripheral nerve stimulator. The patient position is patient should lie supine with legs slightly abducted and externally rotated. I will show on my workstation, and then goal should be local anesthetic spread in the actually this obturator nerve lies between the facial plane of all the adductor muscles, adductor longus, adductor brevis and adductor magnus. The anterior division lies between adductor longus and brevis, and the posterior division lies between the adductor brevis and adductor magnus. So it is again like tab block, it is again a transfacial block, and first of all your main goal is towards the femoral artery. When you see the femoral, just put a transducer parallel with the inguinal crease, and you will see the femoral artery. Then you move medially towards the adductor compartment. Then when you move medially, then there is a this femoral vein is there. Then first muscle which comes, that is known as pectineus muscle, and after pectineus muscle you will see the 3 adductor muscles, and you will see that the shiny interfacial planes between adductor longus and brevis, because it is the obturator nerve is the flattest nerve present in our body. So you can't see the obturator nerve in that individually. So you have to again inject the local anesthetic between the planes. Identify a usual. I will show this Y-shaped facial convergence, where the the opening of the Y is occupied by the pectineus muscle. The adductor longus is present above the one limb of Y, and adductor brevis below, and below the adductor brevis there is a adductor magnus is there. So I will show this while demonstrating on patient, and this is the position you use and position of the probe, that is you have to keep the probe in the adductor compartment more medial to the position when you give femoral nerve block. So your probe should be in the most medial position, and this is how you put the in plane block. This is pectineus muscle, this is again adductor longus, adductor brevis and adductor magnus. So these are the shiny interfacial compartments where the obturator anterior branch of the obturator nerve lies, and this is the part where the posterior division lies. Effect of the block. Actually the cutaneous innervation of obturator nerve is is very highly variable, and therefore sensory testing has limited value. So what you do, the classical assessment of successful obturator nerve block is you have to test the working of the adductor muscle. So you ask the patient to adduct the thigh against the resistance, and if the block is successful, then patient is not able to adduct his thighs. So it is just assessing the effect is by the assessing the motor function of the muscles. The clinical pearl is in plane technique may result in trauma to the great saphenous or femoral vein. So even I also in my practice I use out of plane for adductor because for that you have to be more more practice with in plane technique, and you should know how to put how to see the should be more careful where is the tip of the needle is there, because that is through impingement technique. It's not in plane technique you see your needle is going, but again the when you are putting in plane technique, the vessels are lie in your path. So there might be chances that you injure the femoral vein or Cephalus vein, also, obturator vein. So, out of plane, now I am using in my day to day practice, I am using out of plane technique. Thank you. Any question? Yeah.